To introduce a collaborator, but also a friend, Dr. Raj Sengupta from the RNRHD. I need always to read what RNRHD means because I always forget about it, which is Royal National Hospital for Rheumatic Diseases. And I mean, there are so many things to say about Raj, and I've also prepared a list of professional roles and membership, but then talking to Raj was like, do we really need to do that? And I'd rather tell you a couple of stories about Raj and myself. And so we spend usually lots of time in the Caffè Nero. I use that word because it's an Italian word, and it was useful to say something properly during this kind of introduction. And we can spend lots of time there, and I learned a lot. So Raj is a great communicator, you will see that. And I learned a lot about axial spondyloarthritis, ankylosing spondylitis. I mean, I think I learned a lot. I hope I learned a lot. But the best thing to me was related to the curiosity towards science and the love towards technology that Raj does have. And I do believe that's a very, very, very particular and important thing for a medical doctor. From an engineer, is a very good thing to say. And I still remember that time in which he asked me to explain in front of a cappuccino, second Italian word, to talk about explain what's the inverse dynamics, what's the final element model is, and then we went through that, and it was a fantastic moment. So I think without further ado, I'll leave the scene to Raj, and you will see how a medical doctor can apply technology in clinical practice.
Thank you, Dario. I was really worried what you were going to talk about there, but thankfully that was quite mild. So thank you to camera, thank you to everyone at the University of Bath for inviting me. This is a slightly different talk to the ones I normally do around axial spondyloarthritis because I've had to venture out of my comfort zone and think about technology. But what I'm hopefully trying to do with this talk is to think about a patient before they've got a diagnosis. Once they've got a diagnosis and you're then following them up, you then have to think about how you're going to monitor that disease and then think about things like patient support tools ongoing. So this is a condition that I try and treat every day. And I have about 1,000 patients with this condition. What you see here is a US Marine who was pictured over 25 years. What you see is the loss of lumbar lordosis in his spine. Sorry, this pointer is not going to work very well. Loss of lumbar lordosis in his spine, the exaggerated thoracic kyphus, and his knees are in a flexed position due to bad hip disease. What's clear from this picture is it's a very debilitating disease. We don't still have a good treatment that will prevent the progression. The other tragic thing about this condition is the delay in diagnosis. So it takes about 8 to 10 years to diagnose this condition. And this is some research that a guy called Carl Gaffney and I did about 2 years ago. Why is the diagnosis so delayed? It's a number of different reasons. One is it's a very complex disease. The second is that the classification criteria we have for the disease, or the diagnostic criteria, are very complex. As I'll show you in a second, the awareness amongst the population, so people with back pain and healthcare professionals, is quite poor. Clinical examination in early disease is not very helpful. It's really quite hard for patients and people to reach the right expert. MRI scanning we thought was going to revolutionize how we diagnose these patients, but in fact it may have taken us slightly backwards. And there's probably a whole host of other reasons which we just don't know as yet. From a patient's perspective before diagnosis, we've got to imagine that these are people under the age of 45 typically. They've got back pain and they're going to healthcare professionals saying what's wrong. And often they'll get the message back, it's growing pains, it's related to your work, there's nothing wrong with you, it's related to sport. So we tried to do a little bit of an analysis with a big data company called Black Swan in London. And they looked at all the mentions of back pain and ankylosing spondylitis on Twitter and blogs and websites over a 3-month period in 2016. And very interestingly, they found that 112,000 mentions of back pain per month globally. The majority of those were occurring on Twitter. When it comes to ankylosing spondylitis, 17,000 mentions of back pain per month, and again, mainly on Twitter. If you then look at the demographics of the people who are commenting, particularly on Twitter, with back pain, you had an equal prevalence of men and women. What you also see in the bottom chart is the timing of those comments being made, and the majority of the comments coming in the beginning of the day and at lunchtime. When you look at ankylosing spondylitis, it's totally different, in fact. And here, the real surprise to us was it was 80% of women who were posting about ankylosing spondylitis and 20% of men. The reason this is surprising is we've always thought this is predominantly a male disease. There's usually around 70% men, 30% women who get the condition. So why could this be? And we attributed it to two things. Firstly, because women are going to healthcare professionals saying, could I have this diagnosis, and are being told there's nothing wrong with you because women don't get the condition, we think a lot more women are looking these things up on social media. And the second thing we think is blokes are just rubbish at looking for information and often moaning to they're nodding heads at the front, it's terrible, are looking to their girlfriends and wives to look up the information on their behalf. But all this is quite revealing. Perhaps the most revealing thing to me also was that through the qualitative analysis, you could then see that a fifth of the posts were before people got a diagnosis. So before diagnosis, a fifth of those people are looking on social media for information. So my sort of thoughts and ideas on this front really were, how can we optimally use social media to facilitate earlier diagnosis? Can we get rid of that 7-8 year delay by tapping into social media posts? Now, because of GDPR and data protection, this is difficult to achieve, but if anyone in the audience knows how we can tap into individual people's Twitter feeds, if they are constantly talking about back pain, if they are under the age of 45, to say you fit a demographic, you should go and see your GP about it. In clinical practice, we use these criteria for back pain to separate people who have everyday back pain versus those who may have ankylosing spondylitis. I always regret showing these kind of slides amongst non-patients because often people are sat there going, but that's me, I might have that. Majority of you won't, so please relax. So essentially inflammatory back pain starts at the age under 40. It's likely to come on gradually and not be acute or sudden. Typically, people with this kind of back pain will say they can't sit still for like 3 hours in a chair. They have to get up and move, and it doesn't improve with rest. A lot of patients with ankylosing spondylitis have to get up during the night. So they can go off to sleep fine, but at 1 o'clock, 2 o'clock in the morning, getting up, having a few steps, and coming back down and sleeping is a requirement. And stiffness in your spine in the morning that's lasting at least half an hour is usually quite indicative of the condition. Now, you may sit there and say, well, that's pretty easy. Why aren't we diagnosing all our patients really quickly if it's that easy to kind of separate? In clinical practice, in fact, it isn't that simple, and a lot of the mechanical back pain patients may well tick yes to those questions and boxes. To try and take this out to Joe Public, we were involved in a project some 7 years ago on that website called Don't Turn Your Back on It. We had a campaign in the middle of Bath outside the Apple store, and they had dancers there, and we stopped people with back pain and got them to fill in this questionnaire. So the inflammatory back pain questions I showed you were sort of transported onto this website. People with back pain, because remember, they're not patients yet, could click on the Take the Symptom Checker box. The features of inflammatory back pain were there. They'd click Submit, and they'd get a mini report to say, you look like you may have ankylosing spondylitis. Take this bit of paper to your GP and discuss it further. Now, that's all well and good, but what we actually found is people with back pain rarely find the website. You can't get them to go to the website and tick all these boxes. So what is the best way to get these websites to Joe Public? We've had ideas such as put them on coasters in a pub. that people might look at, scan a QR code and go to a website, or go and put these posters up in gyms, because of course these are younger people who are going to the gym, and you may pick them up there. But again, as a group, we've really got to start thinking, it's all well and good devising another website, devising another app, but if the right people aren't getting to it, it's probably a waste of time. From a clinician's perspective before the diagnosis, as I alluded to earlier, it's a challenge. Before diagnosis, if our patients came in looking like this, it would be easy, okay? But our patients never come in looking like this. They actually come in looking like this, okay? So a typical person with ankylosing spondylitis in the early stage who's complaining of those inflammatory back pain symptoms will come in looking like that and say, my back is terrible and I'm not sleeping. So we did a survey some years ago amongst healthcare professionals attending a back pain seminar, and this was from around the UK. And what the chart in the middle showed you is, whilst the majority of the healthcare professionals, and there were 127 in this sample, were either very confident or confident diagnosing mechanical back pain or treating mechanical back pain, actually their confidence with inflammatory back pain is really low. So we thought, this is really important. We need to get healthcare professionals more comfortable with this concept. And again, back 7 years ago, we came up with another website. So this website was called Back in Focus. It took healthcare professionals through individual part of the patient journey, from how you screen them to how you diagnose them, how you treat them and monitor them. Behind each button sat MRI libraries, questionnaires to monitor your patients. But again, we found difficulty getting the healthcare professionals to use these sites. Some years ago, also in Bath, we came up with what was thought to be a more sort of clinician-usable tool in day-to-day practice. And this was a website called the Spade Tool, which was found at that website. A lot of research has been done looking at the features of back pain as well as associated features of ankylosing spondylitis to help diagnose the condition. And here I'm talking about inflammation in the eye, which is anterior uveitis, a rash called psoriasis, inflammatory bowel disease, Crohn's disease, and ulcerative colitis. So anyone who has those complaints, who then gets inflammatory back pain, who's under the age of 45, may well have axial spondyloarthritis. Knowing all of that, Spade Tool encourages the healthcare professional to tick a box that's relevant to the patient in front of them. Based on research that's been done, and there's a paper from a chap called Martin Rudveleit, which he published some 10 years ago, in fact. And then it gives you the probability of that patient in front of you and how likely they are to have ankylosing spondylitis. So on the chart, there are some instructions and clinicians can be guided. We did a little bit of validation work looking at this tool, and we found that if you use the clinician's verdict as the gold standard, using a threshold of 2 seemed to get you a reasonable sensitivity of 86% and a positive predictive value of around 63%. So when I go around giving talks to primary care physicians and physiotherapists, I usually say to them that if you use the Spade Tool and your red dot falls somewhere in the additional tests necessary box or above, please refer them on. But of course, what we don't have is a properly validated study yet. What's lovely about websites is tracking the worldwide use, and over a year you can see that we get a reasonable number of hits. It's around 1,600 hits. The return sessions are poor. So I think a lot of people go there and go, wow, this is fancy, I might use it for one clinic, but getting them to use it recurrently for future clinics doesn't seem to be great. The third thing that we've come up locally in Bath to try and help clinicians is this GP system pop-up tool. So I don't know if you're aware, but GPs use clinical digital systems called EMIS or System 1. And what we've worked on here is that if a GP sat in their surgeries and they've typed in back pain, the system obviously knows if that patient is under the age of 45. If that person is coming with an episode of back pain 3 months or a year before the current episode, it'll put this pop-up up. Furthermore, if the system finds documentation of uveitis, psoriasis, or Crohn's disease, it pulls that through as well and says to the GP, look, you may not see these patients often, but we think this patient may have axial spondyloarthritis. Please consider the diagnosis and refer on if you think appropriate. It's fair to say at this point, most GPs may see a maximum of 5 or 6 of these patients per year. And I can say this because my father was a GP, but having to know a little bit about loads of different conditions and remember this one is a tough call. So these kind of things I'm hoping will help us move forward. So my thoughts and ideas on this section are the SPADE tool, the EMIS pop-up system tool. We need a prospective validation in a study to see if these tools work and to get it more used sort of countrywide and even worldwide. Again, my question comes back to how do we get clinicians to use these websites, and should we be moving more towards incorporating these kind of clinical decision aids into a clinician-patient record? Okay, so we're floating through a patient journey, and the patient's now been diagnosed. Just to give you a little bit of background in terms of how we run our clinics and what we're allowed to do, generally we're allowed to see axial spondyloarthritis patients once a year. Okay, so in that time, a patient's going on, living their lives, conditions affecting them, and that once a year appointment is 15 minutes. So in 15 minutes, a patient and I have to help each other. I listen to a patient, patient listens to me. We have to go through X-rays, MRIs, blood tests, clinical examination, plan for the next year moving forward. So far, what we've done is we give our patients a barrage of questionnaires to fill in before they come into clinic, and I'll show you some of those in a second. But we try and use those to gauge what are the important things we should talk about in clinic. But it, from my perspective, is not always ideal. We don't know how often flares are happening. We don't know really how sleep is disturbed. We don't know accurately how many tablets patients are taking. We don't know exactly how many days off work a patient has to take. The real effect of these conditions on individual people is still a bit of a mystery that we try and solve in 15 minutes. So the questionnaires we fill, we call patient-reported outcome measures. And just to give you an idea, a typical Wednesday afternoon clinic, this might be, no joke, 2 patients' notes. Okay, so I have to try and digest some of that before 2 of the patients will walk in. These are the questionnaires we collect in ankylosing spondylitis, and this is where Bath is amazing. So these questionnaires were born in Bath by one of my predecessors called Andre Carlin, who some of you in the room may know. But the BASDI stands for the Bath Ankylosing Spondylitis Disease Activity Index. And that's a series of 6 questions which look at fatigue, 3 questions on pain, and 2 questions on morning stiffness. The ASCOL is a quality of life measure. The BASFI is really important, is the Bath Ankylosing Spondylitis Functional Index. It's got 10 questions asking patients how difficult they find to do certain activities. And one of the things which I'll touch on later, which Daria and I are hoping to do, is to objectify that. So have a combination of how difficult a patient is finding it to do, as well as measuring them doing it, we think will take us forward. The Work Productivity and Activity Index, the WPI, looks at features of absenteeism, so taking time off work, presenteeism, where patients turn up to work but have difficulty doing their work, and a combination of those factors. I touched on sleep being very important in ankylosing spondylitis, so we collect the Jenkins Sleep questionnaire, and fatigue is really important in all rheumatic diseases. And my plea to anyone in this room is, clinicians don't ask about fatigue because we don't know what to do about it. So the kind of response is, well, just let's not ask about it because then we won't really need to perhaps address it. But our patients really struggle with fatigue. Fatigue is a major problem. So more research into fatigue, why it happens, how to measure it, what to do about it is very much required. I'll skip through some of this slide, but just to give you an idea, that when patients come to our clinic, they're turning up 15 minutes early, they get the set of questionnaires. Some people will score it before, some people after, but the scoring is often done after they leave, and it's filed in those piles of notes where you don't really see those serial results. So the problem with giving questionnaires is that our nurses don't always give it to the patients are rushing to fill it in, so it may not always be as accurate as we want it to be. Sometimes it's done by other healthcare professionals and not seen by the clinician. When it comes to us bad clinicians, we don't always score it. If you don't score it, it's not influencing your treatment decision, and people forget how to score questionnaires. So the BASDI does have a little bit of tricky scoring. You have to average the last two questions, add them all up together and divide by 5, and that's not often done properly. And the problem, of course, is you keep filing these in notes, you're never looking at those serial measurements over time. So a few digital bits of progress on our front. We've now got, dare I use the word iPads or generic tablet devices in our clinics to collect these outcome measures, and patients have accepted it reasonably well. A few years ago, we came up with something. This was a more national project called Talking AS. So those questionnaires I showed you are on the NHS secure system now, the N3 network, and patients can then fill this in from anywhere. So I had a patient who was on business in China. He filled his questionnaires in. He was really pleased he'd done it. And we were able to see those results in real time in the clinical setting. What is nice about doing it this way is then you really see changes. And I think this is really powerful for a clinician and a patient. Our patients have always fed back to me, they love seeing their progress, and over a chart they can track it. Here what I'm showing you is an individual patient's BASDI, BASFI scores, and you can see they're really static between sort of January 13 to January 16, but suddenly this massive flare comes that doesn't settle at all. And in fact, it carries on, for about 7-8 months, and that drop comes from initiating the biologic injectable drugs. Okay, so Talking AS is used in 40 hospitals around the UK. There are about 1,800 patients registered on the site, and there are around 500 or 600 patients filling in these questionnaires every month. The other measurement that's really important in ankylosing spondylitis is the BASMI, that's the Bath Ankylosing Spondylitis Metrology Index. It involves 5 measurements that you see on the left: the tragus to wall distance, lumbar flexion, lumbar side flexion, intermalleolar distance, and cervical rotation. And once those measurements are done, they are put against a chart there, and you get a score between 0 and 10. Now, our physiotherapists try and do this once a year. It is time consuming. It takes 10 minutes, but the reason this score is brilliant is it's the most objective thing that we have to measure a patient's progress. And our physiotherapists used to write all the scores down on cards, and we have 30 to 40 years of scores for some of these patients. About 2 years ago, we got a grant to allow a guy called John. He sat there, bless him, for a year and transcribed all these scores from a card onto a computer. Respect to the man. But actually what it did was then allowed me to look at these scores with patients in clinic and get some real life stories about how the condition has affected them. So here's one patient. His initial presentation was within 7 symptoms of symptom onset, so he got his diagnosis quite quickly. But he was in his mid-20s, and he said, look, when I first got that diagnosis, it scared me so much, I didn't want to know, head buried in the sand. I just left the place and didn't go back for the next 5 years. In that time, his metrology has deteriorated. He was a 0.9, and then he goes to a 4. Because he didn't engage with the right stretches and exercises, because he didn't listen to how to manage the condition, it was too late. And what you see from him is once that deterioration's happened, no matter what you do, it's fixed. So the timing, getting our patients' psychological status sort of respected, understood, and then treat them properly is really key. Similar story here. Another young bloke, in fact, few years, didn't want to know, came back, BASMI's really high and fixed. Another person, and so I'm really interested in life events when it comes to these conditions. So this patient, I sat with him and I said, look, you did really well for those first few years, BASME scores under 1, and you have that blip in the middle. What happened there? And he said, massive stress, going through a divorce, my job was really tricky, I just didn't have the time for stretching and exercises, and that's what happened. And he then gets into that fixed position with his mobility metrology, and you just can't reverse it. So it's really important to measure, and it's really important to show patients because it will motivate them to stretch and exercise. So what I've tried to show you there is some of the outcome measures we collect, and just to give you a flavour of the volume of data we have on axial spondyloarthritis patients. So 1,206 patients with data. There's an earlier stage of disease we call non-radiographic axial spondyloarthritis. So there's 203 of those patients. The patient recorded outcomes, we've got 27 years of data. The earliest BASME was recorded in 1973. And I found out today we run a 2-week rehab course, which I'll talk to you about in a minute, started in 1972. So, you know, I consider myself to be young, but that's the year I was born. So 46 years ago, the first course happened. And thanks to John, we have a whopping 34,173 individual BASME scores to look at from a research perspective. So thoughts and ideas, you know, retrospective data has its challenges, but I truly believe that it can give us a good idea about which are the best patients to treat with these interventions. What's the right time to treat them? You know, should you start a biologic early and then get them some rehab, get them educated early? The combination of treatments and the optimal combination and timing of those treatments needs analysis, and we've got some of that going on. So bringing us into slightly more sort of modern times, as it were, most people seem to have these devices on their wrists. I think with things like Fitbits, people get excited for a few weeks and then lose interest. But I truly believe if we as clinicians look at Fitbit data on a regular basis, I think patients would wear them more often. These devices can collect a plethora of data from step counts and sleep and calories, heart rate, and the data collection is getting better and better. So a couple of interesting studies that I came across. The first study was a global study where they had nearly 970,000 people using an app to measure step counts. And you can see global step counts from this chart. The Russians clearly like doing a lot of walking, but in Pakistan and Malaysia, they don't. Their step count is really very low. They then looked at some sort of subgroup analyses, and there's some quite obvious things here in terms of if you look at step counts during the week, you see the peaks in the morning when people are going to work and in the evening when they're leaving, but at weekends you get much more of a steady plateau. The other interesting thing I thought that they looked at in the study was the step count by gender, and maybe some of you in the audience have explanations for this, but I didn't really see why men do more steps than women. But you can see as people get older, be it male or female, the number of steps really do drop. When we look at BMI, there certainly is a peak at optimal BMI of 20, but if you have a low or a very high BMI, your step counts aren't great. The next study is more in the rheumatological field, and I thought this was very relevant to my practice. So here they looked at patients with ankylosing spondylitis and rheumatoid arthritis over 3 months and got them to have a wearable on, and they reported flares. In this study, what they showed is that for the patients reporting flares, most of the flares lasted between 2 and 3 days. And during flares, their step counts dropped by about 25%. What this group are hoping to do, and hopefully we'll try and do the same before them, is that they're looking at the period before the flare, look at all these parameters to see if they can then predict the flare and guide the patient as to what they should do to prevent that flare from becoming a permanent fixture. So as I said, we've started something similar. We've worked with a company called U-Motif and developed Project Nightingale. So U-Motif have this sort of petal flower app, and on each of those petals you have a symptom from flares and pain and mood and sleep, and the patients can log on and push the petal out as to record the severity of the symptom. So our patients, we've had 250 patients register on the system, but only 100 are filling it in on a daily basis and have done so for 6 months. Some people have said to me, that's not bad, but I kind of want more. So I'm hoping we can build that up to more patients using it on a regular basis. What we're seeing in the clinic is the step counts, which are, of course, automatically coming in. I've got another chart which I can show in terms of sleep patterns and heart rate patterns. And I think for me, one of the challenges going forward is how much of this can we truly automate for the patient? We are going to get the best data when sort of the requirement for the patient really drops. And that's our challenge in the room. Clinically and technologically, we have to make this easy for people to either fill in or have it recorded automatically. So now for those 100 patients, we're starting to see individual patients' pattern of fatigue over time. We can now, for the first time, accurately see flare patterns, when they're coming on, how long they're lasting. And when you just look at the broad, this is just some basic analyses we've got on the 100 patients, but when you look at the broad overview, we can see in our patient cohort that the mean step count is around 6,000 steps a day. The mean sleep is around 6 hours a night. So it is definitely lower. Subsequent analyses are looking at the timing of when that poor sleep is, how refreshed and unrefreshed it is. But at a basic level, we can see that the sleep reported and measured by our patients is definitely low. And again, similar to the French study I showed you, the flares tend to, for most patients, tend to last between 2 and 4 days. Okay? Which I think is, at least shows consistency with other studies. I'm not expecting you to read that, but where we're hoping to go with that data is to look at the sort of parameters like that in more detail. So just to talk you through the top one, what are the flare patterns? How often do they occur? How long do they last? How does it affect other variables like step counts and sleep, medication use, exercise adherence, and can we predict that flare coming on? So I'm in the process of trying to get some funding to have a postdoc who can do these analyses and then guide us in terms of our patients. What I'm also hoping to do with that data is working, Simon Jones isn't here, so Simon Jones and his PhD, Will Zhang, are experts in the CHI field, the computer-human interaction. So one of the ideas we have is, for example, if we can show one patient what they're like against 99 other people to see how they're doing, I think that's very helpful. And then just the kind of mean overview of this is what a flare looks like and can we predict you're coming into one, those kind of things we hope will change how we manage and track the patients. Going back to that piece around seeing patients once a year is not good enough, but if we can have really good data for that whole year up to the point we see them and a bit of sort of big data machine learning guiding us as to what we should do, I think would take us a huge step forward. So this is some work Dario's been involved with us. So a few years ago, I got some funding to buy this kit called ViMove, some spinal sensors going on the patient's back. And we've tried to use this to measure patients before and after they've done our 2-week rehab program. And there's a lot more data produced than when we do our simple BASME measurement. And I'm just showing you again a basic chart of the different ranges of movement and the improvements that we might see. And the improvement in this patient was around 30%. But what was interesting about this bit of kit is if you keep it on, you can see patients moving in real time. You're not just confined to, I'm measuring you at time point 0 and I'm measuring you at time point 14 days. You're really getting live data all the way through the course. And so with Darius' study, what we're hoping to do is to take this a bit further with this musculoskeletal modeling. The first study that we're looking at is trying to assess ankylosing spondylitis patients and their ability to work. So we know that a lot of these people have to take time off work. It's around 15–20%. And they're taking time off work because desk-based work is often very difficult. So using this kind of modeling, can we predict those who are going to have difficulty at work? Can we optimize their workstations so they're likely to stay at work longer? We're hoping we can apply the same things to driving, because I think driving is a huge challenge for ankylosing spondylitis who patients can't look over their neck. And I talked about the functional measurement with Dario, and the other piece with Dario's work that I'm really excited about is we still struggle really predicting prognosis. And with Dario's work, we're hoping that by looking at musculoskeletal modeling, looking at spinal muscle load, looking at EMG measurements, can we pick out those patients in early disease who are most likely to progress and intervene quickly? So that's exciting work coming forward. And then with Darren, so Darren, this is where you find out what might come. And Matt, the BASME measurement, which is used worldwide, we're hoping to digitize that. So here, at the moment, if a patient wants to get measured, they have to come into hospital. We need 10–15 minutes of a physiotherapist's time, and so resources are heavy. With iPhones and AR kits and other little bits of work, what we are hoping to do is if we can put the iPhone in front of the patient, give them voice instructions to do the moves that they need to do, hopefully the system's clever enough to even spot where patients are not standing in the right position to do those movements. We can then allow the patients to do their own tracking from home. Again, if we can collect volumes of data, we can compare, build the models, look at big data, and try and guide patients moving forward. So I talked about objectifying the BASFE, understanding and doing the research to predict those axial spondyloarthritis patients who are most likely to progress, and coming back to that point around allowing easier ways to sort of automate disease assessment and measurement, be through wearable data or home BASME assessments. Okay, getting there. How long have I? So I've got about 10–15 minutes. The other big piece of work I think we need to do is around imaging in ankylosing spondylitis. The two main forms of imaging we use are MRIs and X-rays. We know now with MRIs, the progression that happens is inflammation on a specific stir sequence where the fat is suppressed, to erosions, which are structural changes in the sorry, I don't have a pointer that's working very well, but the sacroiliac joints, the erosions that you're seeing in the middle picture, to full fat formation and fusion that you're seeing on the picture on the right. So in this, just to kind of detail that a bit more, we're talking about a process of inflammation that then develops into fat and causes structural change with erosions, that then goes on to form new bone formation and fusion. And that's where, going back to the original picture I showed you, the man is unfortunately like that because he's had new bone forming all the way through his lumbar thoracic and cervical spine. It's a disaster if we can't treat this properly. With the biologic drugs we have now, cost is a challenge, and the timing of the treatment is a challenge. We're treating people with these biologic drugs too late. If we could diagnose the patients earlier, treat them with the biologic drugs, we would switch the inflammation off and stop it becoming fat and forming the new bone. And X-rays are a challenge because if you put 100 radiologists to read the X-ray on the left, 50 would come out with one message and 50 would come out with another. So the variability in that reading is difficult. So currently what happens is I might send a patient for an MRI and the radiologist will send me a report back and go, this patient has active sacroiliitis. There is a degree of bone marrow edema in the sacroiliac joints. And the reporting is very not qualitative, but it's a very open-ended, and there's no sort of structure really. And this is not a criticism of radiologists, but they've got a lot of work to do and they don't have the time to go into the reports in great detail. Yet I haven't got the studies to show you, but there's a hell of a lot of research that now shows that the degree of the MRI inflammation is associated with X-ray progression and patients doing that. The degree of MRI inflammation is also indicative of the likelihood of your response to biologic treatments, okay? We're not quantifying that inflammatory change mainly because of time constraints. So one of my pleas has always been that, you know, we've got tons of images in the hospital, of MRI images, X-ray images, and it would be really nice to train a computer to do some of that reading, and hopefully then we'd be able to have a patient who comes in, has the MRI, automatic reporting, grading of the amount of sacroiliitis, and help clinicians better select the right patients for the treatment. So once someone has a diagnosis, and I put this picture in, he's a patient of mine, and I thought this picture really kind of shows us the day-to-day impact of living with the condition. And you know, he's a lovely guy, and he said to me, just even playing a game of pool and having to look up at the pocket is quite hard work. And the fatigue that's associated with that really is massive. So my plea in this section is there are a lot of decision aids for patients that are now on paper or on a website, and they look like this. You know, here's an introduction, here are your options, write down some notes on what you think and what do you want to decide. But I just don't feel that these things live. You know, they're on a website. It's really hard for patients to kind of comprehend. Here's another one for a drug we use a lot called methotrexate in rheumatoid arthritis. Lovely little flowchart. But if you're a patient at home, this doesn't work. This was a Cochrane review looking, I think this one was with anti-inflammatories, but we have these on disease-modifying drugs, we have them on exercise, and patients are sent home to look at those, but I really don't know what they take away from it. Moving this slightly forward, a website called ClearMD now exists. This is an Australian rheumatologist called Erwin Lim, and what this website is aimed to do is to create short 2-minute, 1-minute clips on specific questions in arthritis. And I like that. So I think if a patient with rheumatoid arthritis, I would send them to a website and say, if you've got any questions, look at those videos first. If they don't answer your questions, then come back by all means and ask us. And I think we may need more of that, but people have to be directed. There are a ton of apps that we can recommend. Top one around weight loss and tracking what you eat. Another one for mindfulness, calm, and another one with short video clips as well to try and guide patients. I really like the Lose It app because it enables you to take a picture of your meal, and there's some machine learning being built into that so that the picture will then be interpreted to say you've had 3 sausages and a few beans and mashed potato. So tracking patient diaries will become easier for us. Now, the reason that's important is the gut microbiome in ankylosing spondylitis is becoming more and more relevant. So we think that the microbiome may well be related to the onset of the disease and how your disease progresses. Mindfulness, another really important thing that we use to treat our patients with, another app. How much patients use these apps, how we can fit it into their day-to-day management over that year still has to be worked out. I do think, and I'm not an Apple employee, but I do think Apple and Google are probably the platforms we should try and push towards. The reason being, most people will either have an Android phone or an iPhone, and I think we will be able to get mass take-up if we can use those platforms to push anything we do out. Okay, so I'm not sure this will work. So Simon Jones has put in a proposal to AR UK to try and bring a lot of this through the Alexa support program. So I don't think it's going to work. But, you know, you'd say to Alexa, I'd like to log my medication.
Which medications have you taken today?
Nearly. Which medications have you taken today? There's some more examples.
Here's your daily reminder to take your tablets. Is there anything you'd like to ask me about your
medications?
Most disease-modifying medications, or DMARDs, take 8 to 12 weeks to be effective, particularly if they require a gradual dose increase. Some people notice an improvement even earlier than that. How confident do you feel that you can take
Alexa.
actions that will help?
So I think the Alexa bit is quite exciting for me, and I think where we will need to do the work is to find out the commonly asked questions, develop that into Alexa, and then test it out. But I think that is the way forward. So I think if patients are sat at home and they're thinking, you know, I've got an infection, I'm on a biologic drug, I can't remember what the doctor or nurse said about whether I should take it or not. Alexa, is it safe for me to take this drug? An answer comes back. For the routinely asked questions that don't have any implication from a safety perspective, I think this would be the next step forward. So I think my comment there are lots of lovely patient decision aids that a lot of people have put a lot of hard work into, but they definitely need bringing to life. A good example, Arthritis Research UK has in fact changed their name recently, some of you may know, to Versus Arthritis. But look at their website, because they've developed a sort of chatbot for arthritis, and I love it. And I think developing something like that for axial spondyloarthritis would be good. And as I said, I think Apple or Google Health apps should be the kind of base on what we do going forward. So just racing through some of the last few slides. So this is what our 2-week rehabilitation program for axial spondyloarthritis looked like 15 years ago, because that's all the pictures I could find. But it's similar sort of things that actually happen now. We have a little bit of research behind it, because it is so hard to do a sort of sham physiotherapy type study, but we tend to improve patient-reported outcome measures by 20 to 25% across the BASDAR, BASFI, and BASME. We currently deliver it in 3 groups measured by the BASME, so you have a sort of severe group, a moderate group, and a mild group. But at this stage, who goes onto the course? I pretty much decide that in clinic. I try and pick on patients who've got a new diagnosis, because as I showed you on those BASME charts, the quicker I can get the right education and right understanding of the stretches to do, the better the longer term results I'm going to see. Patients who start biologic treatments and get rid of the pain and stiffness, getting them onto a course yields really good results. We do have some people who come back on a sort of every 2-year basis to try and keep their BASME level. But there's no science behind me getting that patient on the course. And I'd like to think with the retrospective data, we might start answering some of the questions around the right patient profile of getting that person in at the right time. We're also doing a lot of work with the course, the physiotherapists, to see which are the right stretches that are right for that patient, because their neck is worse than their back. But we need to do that research to kind of really develop that, I think, going forward. And then it's rethinking that patient pathway. You know, if a patient's doing their own BASME at home, if their wearable data is saying to them, look, things are not going the right way, now is the time you need to come in a course, and that may be every 5 years, that would be a much better targeted way to deliver care. And just finishing on the biologic treatments. So, you know, I'm so pleased I'm a rheumatologist in 2018. 20 years ago, all those clinicians had was anti-inflammatories. And those clinicians had to just see a patient every year and say, there's nothing more I can do for you, and watch them potentially deteriorate. These drugs have transformed care, not for everyone, but a fair number of patients. Initially, they were £10,000 a year, which is why we were slightly trapped, but the price is coming down all the time. And so when these patients have had these drugs, people come back to me and say, miracle, I can now pick up my child, I've stopped taking time off work, I've written a book. One guy who's a professor of music even wrote a sort of classical piece of music based on one of these drugs that was played at Wells Cathedral, because it inspired and changed his life so much. If you look at MRI scans, they get rid of inflammation even after 1 or 2 injections. So at the top, I don't know if you can see in the middle picture, there's a halo of white around 2 vertebral bodies, and that is intense inflammation. And if you look at the 12-week scan below, it's gone. It absolutely magics it away. Now, what I've tried to do here is just, as I finish off, show you in that patient journey from a retrospective point of view. We have a hodgepodge of stuff. So, you know, there are some patients who've had MRI done, they've done a rehab course, they've had an X-ray taken, they've had some biomarkers taken. But what I'm really hoping, again, as I said, with the retrospective data, is we can start answering some of those questions to pick out the ideal time for treatment. And so we've got that data brewing, and we will hopefully see whether we can make it work. So putting it all together, diagnostic aids, digitizing them and making them very patient-friendly. Once we have a new patient, again, that digital data collection automated as much as possible. I do think biomarkers in terms of blood tests taken will be moving us forward when we found the right one, which is in process. I'd love to do more with psychological profiling. At the moment, sadly, we treat every patient the same. They come in, they've got a condition, you need that drug, off you go. Nothing looking at how that patient might cope, what are those patients' needs, and we need to do more. And then just in the sort of longer term follow-up visits is really think about the wearable aids, the patient decision aids, and digital monitoring. So this is my kind of blue sky thinking. Actually, I created this slide about 5 years ago, but you know, it's still blue sky thinking. So I guess the pre-hospital visit is around completing an online questionnaire or the wearable data. I quite like the idea that when you walk into hospital, the system automatically knows that you're there. You go to a patient information portal and you'll complete your questions for the day. You'll then come across to your imaging portal and your MRI scan will happen automatically as you walk through. A little drop of blood is all that's needed to get all the right biomarkers to tell me whether you're going to progress or not progress. And then you come into the clinician, and actually I'm going to take that last bit out because you're not going to need a clinician because it's all going to be done for you, and then you'll be able to walk out with an answer. But joking aside, I think we will need the clinician because I think, so when I spoke at a patient conference last year, patients quite clearly said, look, they want a human. We can do all this bit on the side and it might influence and support what a clinician is going to do for you, but ultimately you do need that clinician there. So just to summarize, just to reiterate, in Bath and through none of my hard work, but hard work done before my time, there is a ton of data from imaging and patient-reported outcome measures. I really want to be one of the clinicians who in sort of 10, 15 years' time can look back and say, look at the way we did it in 2010, 2015. It was so archaic, and we've really changed the game, moved things forward, and altered that patient pathway to optimize it and really get personalized treatment delivered for that patient. And I think it's using the collaborative data that we've got through the digital tools that's going to enable us to do it. So I'll just finish with some of the faces. Apologies if I've forgotten anyone. I always feel crazy when I do this. But this is the Spondyloarthritis Research Consortium that we have at the university now. And we're all trying to work together to achieve some of the stuff I showed you. So with that, I'll stop and take any questions.
Thank you very much, Raj. Is there any question for Raj? I do have a question. Oh, okay.
Thanks, Terry. Raj, thank you. Really nice, clear presentation. And I think it's clear for people in the room to see how we as a university community could get involved in research in this field. I'm intrigued. I could probably talk to you all night, but I'll try and keep it brief. I'm intrigued in the etiology of the condition, and how much do we know about genetic predisposition to this condition versus, how confident are we that it may be lifestyle factors? And I was particularly interested in your comment about the gut microbiome, and there is a lot of ongoing work here, which I think we could play a role in that.
So thank you, James. So HLA-B27 is the main gene that's been identified in this condition, and that was identified all the way back in 1973. Since then, one or two other genes have been shown to play a small part, one of them being ERAP1, but really we haven't moved much further forward than that. A couple of important points about HLA-B27. 8% of the UK population are positive for the gene, but not all of them will get the condition. On the converse, 90% of ankylosing spondylitis patients are positive for the gene, but of course 10% are not. So if you're positive for the gene, you've got a 1 in 15 chance of getting the condition. And that's as far as we've got to really with a lot of genetic research to date. The gut microbiome stuff is very much in its infancy. We're part of a study with Imperial collecting stool on, I think it's 125 ankylosing spondylitis and psoriatic arthritis patients. They're completing patient food diaries, and we're looking at the gut microbiome and a number of serological markers to try and pull that all together. But it's an evolving story. The other piece around, I think it's fascinating to try and work out if a person is HLA-B27 positive, why and when do they get that disease? And there've been so patients will come in and say to me, this all started when I had a rugby injury. This all started when I fell off a ladder. This all started when I had a significant infection. But it's difficult for people to recall it, but you hear stories of trauma and infection being the main triggers for it. Now, so what's fascinating is we know that once you have the condition started, it's stretching and exercises that keep the symptoms at bay. And we would also postulate, we can't prove it yet, is the stretching and exercises that if you're going to fuse, you'll fuse like that. But if you don't exercise and stretch, you fuse like that. So there's something around exercise and trauma that triggers the disease, and then there's something around exercise and stretches that are required to maintain posture. The pathology in this condition is thought to be an enthesitis. So rather than synovitis, which is inflammation of the joint you'd see in rheumatoid, this is inflammation where the tendons and ligaments are inserting into bone. So Achilles tendons, there are tendons in our elbows, in our knees, and in our spine. It's thought that microfracturing trauma of those tendons, the healing process then leads to new bone formation. And it's that recurrent process that then bone, 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 and bone. The other elephant in the room that no one talks about is smoking. So without a doubt, the worst disease I see in patients are in those who've smoked for years and years. One study showed that if you had high disease activity, so your BASDI was high, a man who smokes progressed 12 times more than a woman who doesn't. Smoking is a massive problem in axial spondyloarthritis, and again, that's something I'm not sure we're wholly successful in treating. Sorry, I've rabbited on.
Thank you.
Hi, Raj. I've got a question really around the exercise programme. As both a patient of AS and also a sport rehabilitation student, I'm quite fascinated by the strength and conditioning aspect of how that's supported me, and I just wondered how much research is going into that, because there's a lot of focus on stretching and not so much on the strength and conditioning, and I wondered if there's any progress with that.
So good question, and sad to say no, there isn't a huge amount. So our physios try and combine stretching with a bit more sort of cardiovascular program, but the stretches in the hydrotherapy pool, which I'm sure you probably experienced, makes all the difference. And so getting those patients in the hydrotherapy pool is important. Exactly the sort of types of stretches and strengthening exercises just have never been validated in AS. Partly because, as I say, it's very difficult to do sham exercise. But, there are ways to do crossover trials, which at the moment we're trying with our physiotherapists to work through, but the evidence behind it at the moment is really poor.
Any other question? I do have a question indeed.
Oh, okay.
So I think it was great to see the multidisciplinarity related to axial spondyloarthritis and some biomechanics that could be used to answer lots of questions in relation to the inflammation and so related to muscle attachment and the bone growth for sure. There are some more kind of machine learning related kind of application, could be related to imaging or could be related to big data analysis. But yet, if you think about the funding and the number of papers with respect to other kind of pathologies like OA, for example, to me it strikes me the fact that there is not much there related to axial spondyloarthritis. And my question is, do you think it's related to the complexity of the disease that kind of put researcher a bit off the topic, or is more related to the fact that you need a big manpower to do so, or is it related to the fact that we don't know enough about the etiology of the disease?
Yeah, good question. I think the one thing that would stand out to me probably more than anything is the volume of patients and the volume of the problem. And also, obviously, osteoarthritis is massively common. 2.6 million people go to their GPs with mechanical back pain every year. So I can understand why more priority has to be given to diseases which are more prevalent. I get that. Problem with ankylosing spondylitis is not really a problem, but there are thought to be around 200,000 people in the UK suffering with the condition. So it's not huge in the whole scheme of things, and maybe that's why. What's changed interest in ankylosing spondylitis has been the biologics. So suddenly you've got a drug that works that people are interested in to see how it works and whether it really changes people's lives. But also with it, sadly, you've got a bunch of pharma companies who are suddenly interested in funding big studies to do it. So I think the osteoarthritis story has been much more around volume of patients compared to ankylosing spondylitis. Yeah,
so my point was, there are very good questions from a research perspective that could be answered. And, when I saw that no one has tried to do that before in terms of biomechanics, I was kind of surprised. So that was...
Making you work, Dario.
Got my Fitbit.
Hello again, and thank you for showing us what research has been going on behind the scenes. I was particularly interested in sort of your blue sky thinking, being able to predict sort of what's best interventions along the line. Do you think that will be able to involve predicting, say, who's going to end up with uveitis or inflammatory bowel disease, and therefore would that be able to influence for instance, which biologic you would put somebody on in the first place?
Really good question, Nicholas. So the question that's been asked is really the extra-articular manifestations of the condition, the three most common ones, uveitis, psoriasis, and inflammatory bowel disease. We know that around 30 to 40% of axial spondyloarthritis patients will get uveitis at some point during the disease course. With psoriasis, it's about 10 to 12%, and with inflammatory bowel disease, it's about 8%. At the moment, we don't have any way of predicting who's going to get those conditions at all. There are a couple of biomarkers. There's one called fecal or serum calprotectin that could be measured that may indicate whether ankylosing spondylitis patients might get inflammatory bowel disease, but really we see a lot of false positives in people who are taking anti-inflammatories, so it's not a brilliant test. For uveitis and psoriasis, there's absolutely nothing. Through our PROMISE study, which is a biomarker study in ankylosing spondylitis, we are looking at that group, and so far we've picked up one biomarker which is showing a little bit of promise with uveitis, but we're at a very exploratory stage, certainly not useful for clinical practice. Your other questions around, wouldn't it be lovely to then be able to get the patient with those conditions on the right drug? It's hugely important because we know that certain anti-TNFs can actually deteriorate those extra-articular manifestations. For example, if you use a drug called Embro or etanercept, it causes flares of uveitis. So it'd be, we don't know, we're just guessing. But we're hoping that when we put people on that drug, they don't get bouts of uveitis later on, and we get away with it quite a lot of the time, but not every time. A drug called secukinumab, which inhibits interleukin-17, which has come about for use in ankylosing spondylitis, can cause flares of inflammatory bowel disease. So we would avoid in people with known inflammatory bowel disease, but again, ideally, we shouldn't be using it in people who might get inflammatory bowel disease, but we have no way of knowing now. So a huge amount of work to be done with the extra-articular manifestations in mind.
I'm just wondering, you're moving to the RUH, and whether any of your blue sky thinking is going to be put into what is opening up in the RUH.
Okay. So I think what I see as a real positive about the move is that it's a brand new building. A lot of thought has gone into the design of that building to get the patient flow through correct. The tablets I've talked about, again, a lot of thought has gone into positioning those in the outpatient department and using those properly. Some of you who've worked in the RUH will be aware that a lot of investment has gone into the Millennium patient record, and we're working with that to try and get the patient journey right. In terms of the true blue eyes thinking, I don't think it's so much an RUH, RNRHD issue, but I think it's more of a clinician and researcher issue to put those things into practice, validate their use, test them out, show the benefit, and then put it into practice. So I don't see any negatives about the RUH approach from that side. As I say, with the technology we have, we've really thought about integrating it into the patient pathway, but I think as clinicians and researchers, we need to do more with the other bits of the blue sky thinking.
I'm a patient at the RUH, and Humira gave me uveitis, but because I go to the eye hospital quite often too, and I've experienced a reconfiguration of one of the floors in the eye hospital that caused more problems. So it was the new innovations were worse than the old.
Oh gosh.
So I'm just hoping, and I know how difficult it is. Once you've got a new hospital, no one will want to spend any more money. So I would urge you to consider very, very carefully whether there are things that are working now.
Yeah, no, that's a point well made, and perhaps we can have a conversation in July 2020 when we've been in the new build for a year to see. I hope we wouldn't have got those things wrong, and I'm hoping we haven't got those things wrong because, you know, truly the management of the RUH have had all of us involved at a number of different meetings to talk about these things. So no one's done this without us having some input. But yeah.
You talked to the patients being involved in walking.
Yes. Yeah, the patients were definitely involved in the planning of the building and how it was going to be set up. In terms of have they walked around the new build, not yet, but it's definitely going to happen. Yeah, absolutely. Even patients in wheelchairs.
Well, mainly patients in wheelchairs.
No, well, interestingly, and it's an important point, if you talk to, so some of you may know a man called Professor David Blake, who was a professor of rheumatology at the RNRHD, and you know, he would say in the 80s and 90s, the front of the Min was lined with wheelchairs. And in fact, through the successes of our treatments, we're seeing a lot fewer wheelchairs now than we ever did before. So it's an interesting change in time.
Any other question for Raj? Well, there are some drinks and nibbles outside, so I think it's time to thank Raj for the fantastic presentation. And thank you to you for being here.